Thank you for inviting me here today, and many apologies that I can't be with you in person. I'm Mark Cooke. I'm the Director of Strategy and Transformation for NHS England and Improvement in the South West, and hold a number of portfolios, one of which is to oversee the development and establishment of integrated care systems in the South West. We know that the white paper, Integration and Innovation Working Together to Improve Health and Social Care for All, resulted in a Bill of Parliament, which is now an Act of Parliament. Clinical commissioning groups will cease to exist after the 30th of June 2022 and will be replaced by the formation of integrated care systems, the main NHS body for which will be the Integrated Care Board. More of that later. All of this is preceded by about 7 years worth of work in the NHS, following the 5-year forward view and the NHS long-term plan, to create a way of working that is more integrated and collaborative. One of the key aspects of the legislation is that it's very permissive, flexible, and allows innovation at local level to best serve the needs of their population. We know that the way needs are best met in Truro in rural Cornwall will be very different to those in Manchester, and unusually for the NHS, this is not a top-down, full-scale reorganisation with a set of blueprints. This is an evolution of a different approach, a mindset and culture change to how we work, which has developed over a considerable period of time and still has some way to go. For me, that's a really exciting prospect, as I believe we can never stop learning and improving what we do and how we do it in the best interests of our citizens and communities. As you can see from this slide, ICSs have 4 key purposes: improving outcomes in population health and healthcare, tackling inequalities in outcomes, experience and access, enhancing productivity and value for money, and supporting those broader social and economic development aspects of systems. We'll see later how ICSs have developed in various ways, shapes and sizes, but here are some thoughts and observations on areas behind the policy and legislation that provide us with that chance just to think a bit differently. We will see later examples of how across the country ICSs come in many different shapes and sizes. The NHS is more than just an institution that provides services to patients, of course. It's a complex combination of organisations, cultures and people, and in many ways it's a microcosm of society and has, through its people and other resources it uses, a significant impact on our wider community. We also work with many partners, including, of course, universities and research establishments. What we've set up is very permissive and flexible, but with that comes potential confusion and complexity. Our job is to ensure that for local people and local organisations, it remains simple, clear and effective. We have an opportunity now more than ever before to work collectively on not just the delivery of services to patients, but to improve the health of our population and to look at all the factors that impact on health and well-being, whether that's through a net zero approach to carbon emissions, improving education attainment by supporting families in need and psychological support to young people, right through to understanding and taking action to help people where possible, avoiding needing hip replacements or increasing their risk of acquiring chronic long-term conditions or cancer. This is a real opportunity to think and act differently and is the biggest shift in the way that the NHS has worked in over 2 decades. So what is an integrated care system and what are we creating? Well, in very simple terms, the key elements of an integrated care system can be summarised in 4 big chunks. An integrated care partnership, an ICP, which is the broad alliance of organisations and representatives concerned with improving care, health and well-being of the population. Jointly convened by local authorities and the NHS, this body is responsible for creating the integrated care strategy for its population, drawing heavily on the work of the health and wellbeing boards and the local area's joint strategic needs assessments. Then we have the ICS NHS body itself, the Integrated Care Board, or ICB, and that's an organisation bringing the NHS together locally to improve population and health care. 2 other important ICS features are place-based partnerships, between the NHS, local councils and voluntary organisations, and provider collaboratives, bringing providers together across one or more ICSs to work in networks and alliances, securing benefits to work at scale. So a bit more about integrated care boards. So these are being established tomorrow, 1st of July 2022, and these are the legal NHS bodies that will hold the NHS resources for the local area and potentially, where agreed, joint pool budgets with other partners. These are a new concept, while still having some of the traditional board makeup, as the NHS always does, for example, chair, a set of non-executives and executive directors. They'll also have a minimum of 3 partner members who are there to bring experience and expertise from the 3 sectors within the ICS, namely NHS trusts, primary medical services and local authorities. Importantly, they're not there to represent their organisations. And in addition, one member of the board must have extensive knowledge and experience of mental health services. The Integrated Care Board has to both implement the mandate set for the NHS by government and to have due regard to their role in delivering the integrated care strategy as set out by the Integrated Care Partnership. Place-based partnerships, as I've said, will be critical to ensure that decision-making and service transformation is carried out as close to communities and neighbourhoods as possible. Urban places and rural places, coastal places and so on, all have different challenges and needs. So there's no set definition of a place. And there are many different ways in which places can be led and represented, as can be seen on this slide. It's very much for the local area to determine what works best for them, and we will look at this in more detail very shortly. Finally, it's critically important that providers of NHS services are expected to now collaborate on design and delivery of services rather than compete. Although still separate legal entities, and the legislation has not changed any significant element of how NHS trusts and foundation trusts are set up, there are changes to the way that NHS England regulate them and oversee their work now as part of a system rather than just as individual organisations. I hope this will also apply to areas around research and innovation, which, whilst there are, I'm sure, still an element of competition, there will be more appetite to work collaboratively on areas of mutual interest, or where clear synergies exist from different areas of expertise. And that brings me to, so where does research and innovation fit into the ICS concept? It's fair to say that research and education and innovation is not very prominent in the policy guidance work, nor indeed in the Act itself. We know from the Act that any previous duty of the clinical commissioning group transfers to an integrated care board, and section 17Z40 of the Act sets out the duty in respect of research. Each integrated care board must, in the exercise of its functions, promote first of all research on matters relevant to the health service, and secondly the use of health service evidence obtained from research. But it needs to be recognised that research and innovation will have an important role in all elements of an ICS, as I've just described. We know that the 2012 Health and Social Care Act created considerable fragmentation of the NHS and its relationship with key partners. Now, fortunately, some continued to act in an integrated way despite the 2012 changes, but others did not. And we know from Professor Marmot's work on social determinants and of others that somewhere between 80 and 90% of population health outcomes do not come from the £160 billion we spend on the NHS, but from those wider determinants of health outcome, including education, housing, gainful employment, and our environment. And we, as an anchor institution in the NHS, can also indirectly influence and directly impact on those factors. So it's vitally important that every penny of the money we're given is put to good use and is aligned to those key strategic aims that integrated care systems are being established to deliver. I'm sure you will all strongly agree that it's only through good evaluation of what works, creating new possibilities and approaches through research and innovation, that can reliable evidence be created of what works well and how future services might transform, and then provide appropriate education platforms to spread evidence-based practice and new ideas. So I think there's a real opportunity here to consider what impacts ICSs can have on whole pathways of care and population life cycles. It's also an opportunity to consider what role research and education will have in influencing the thinking through a system lens. This can, if done well, create an environment within which to think differently. But as I've already said, the role in research in integrated care is not as front and centre as it should be. So it's really for you and your colleagues to ensure that your voice is heard in these new arrangements. And here's just an example of how, for example, Greater Manchester Health and Social Care Partnership have included health innovation in their structure, which you can see on the right-hand side in pink. And just to expand on that, this is the way their partners are organised to support that element of research and innovation within the ICS. And I know that many areas are actively thinking about what arrangements need to be in place for their areas. So please ask your local ICS what arrangements are being considered for your area. So what does the Southwest look like from an ICS perspective? I thought it worth spending a couple of minutes on the makeup of the Southwest systems. So the Southwest, with a population of around 6 million, represents just under 10% of the national picture in terms of people, living on almost 20% of the landmass. And it's quicker to get to Carlisle from Tewkesbury than it is from Tewkesbury to Land's End. The average age in the Southwest is 42.6 years, and there's about 230 people per square kilometre, compared to Manchester, who have 10 times as many people per square kilometre and an average age of 38. The exception being places like Bristol, which has a much higher density of 4,300, but a lower average age of 36. We spend over £13 billion of public money on healthcare, which pays our 125,000 staff. On average, as we do have wide variation in our child indicators, generally life expectancy is better, mainly due to our better coronary heart disease and cancer mortality rates. However, that hides a wide variation and some significant issues around things like diabetes, suicide, and pockets of very high deprivation, particularly on our coastal areas, which combine the oldest population in the country, our geography, and the lowest rates of acute hospital beds, means that we can often operate in a very challenging environment, and that is often hidden with our overall average position. In terms of the makeup of our systems, we have 7 in total, with only 1 covering a population of more than 1 million in Devon. And there are varying definitions of place, Bristol, North Somerset, South Gloucestershire having the most with 6, and Gloucestershire and Somerset using the same footprint for place as the ICS. Devon has most primary care networks, unsurprisingly, given its size, and most have 2 or more NHS trusts, although Somerset is moving towards only having 1. And we're in the fortunate position of having a one-to-one relationship between former CCGs and the new ICS, and no boundary changes, which has made the transition to the new organisations much easier, and in lots of ways more straightforward. But it's really important to stress that ICBs are not just a new form of CCGs. They will be very different, as I've already described. All ICSs in the Southwest are coterminous with 1 or more upper tier local authorities, which makes it ideal to take partnership working forward and keep a focus on population health outcomes, which in local authorities is critical. If not, they have a primary role, given that around 80% of healthcare outcomes are determined by non-NHS interventions, as I've already mentioned. Just to further illustrate the differences with our ICSs compared to a couple of large ones, on the right-hand side of the slide, you can see Manchester and West Yorkshire and Harrogate, each of which equates to about half the size of the Southwest. But there is not the same rationale for putting 3 or 4 of the Southwest ICSs together because of that focus on population health management and because of our specific geography. So I hope that gives you a flavour of the new world of integrated care systems and how it applies to the Southwest. You're very welcome to contact me if you'd like any more detail or want to ask specific questions. And once again, many apologies for not being able to be with you today. Thank you.